This will be a very brief introduction into macular holes. It's a good starting point, and there will be many other sections in the audio atlas on this particular disease, going into much more of the different clinical appearances, the different stages, and the treatments. There are three different styles of macular holes. There are full thickness macular holes, macular pseudoholes, and macular lamellar holes. In this particular audio atlas section, we'll be dealing only with the full thickness macular holes. The demographics of idiopathic macular holes show that the patients are usually in the older population. The median age is 68. Now, you can get it in the ages of any time at age above 50, 55 or so. If the patients are younger than that, they will almost always have a secondary disease or some trauma. For some reason, the gender ratio is 2:1 female to male. It can be bilateral in about 15% of the time. Usually, there are no antecedent symptoms, meaning someone will come in and say, my vision's been gradually getting worse for 6 months. No. They will come in and say, you know, my vision really changed in the past month, and I closed my one eye and I just can't see in the central area. The pathogenesis to the development of most macular holes is a partial parafoveal vitreous detachment, and this is the first initial stage of a posterior vitreous detachment formation. And there's a parafoveal bursa, and the vitreous is still attached to the fovea, and that can cause some anterior traction, disruption of the retina, and the formation of a macular hole. You should get to know the different clinical appearances to a macular hole. It can have a yellow fovea. There can be a yellow ring around the fovea, just a decreased foveal reflex, but most commonly there's a small red spot, and that can come up to about 500 microns. There can also be some pigment mottling around it, or small little drusenioid changes in the middle. You can find the differential on this in other audio atlas sections. When you start out, you'll notice that depending on what papers you read and when they were published, there are different classification systems to macular holes. Dr. Don Gass had the first classification system, and he developed that prior to the OCT. In 2013, the international classification came out, so you should be well aware of both of those, because you'll be discussing this with various attendings and with the patients, so you do need to know the different systems because they are both still in use. So here are two different classification systems. On the left-hand side is the international, and it has everything from vitreomacular adhesion on down to the full thickness macular hole, and that was separated out into small, medium, and large. Lamellar macular holes and pseudo holes are a totally different subject that will be covered later. The Don Gass classification of the vitreomacular traction was his stage 1A and 1B, and the full thickness macular holes, small, medium, and large, were his stages 2, 3, and 4. So there are papers out there on each, and those are both of them you should be familiar with as you go on with your training. So here's a clinical photograph on the left of a macular hole. You can see that there's a yellow-orange look to the fovea. It is not totally normal, but it's not a bright red look as some stage 4 macular holes can have. There's a sheen around it. This is a mild epiretinal membrane. The OCT on the right-hand side shows this vitreomacular traction coming down to the fovea, and you can see very clearly there's a full thickness defect in the retina. Here's another photograph of a patient with a macular hole. Vision is blurred 20/60, which is typical, only for 1 month. If you look in, there's a yellow ring. This is one of the stages in clinical presentations noted by Dr. Gass. On the left, this is the same patient. This is a red-free photograph. And the OCT shows the same vitreomacular traction. You can see the line where the arrows point, and this is the back surface of the vitreous, and it is pulling on the retina, and this is a full thickness macular hole. And this is a very, very classic appearance of a very large macular hole. There's no retinal tissue centrally, and you can see directly down to the retinal pigment epithelium. It's got a very large red look to it. This is very classic of a macular hole. Nothing else is going to look like it. And here's an older style OCT, a stratus, showing a macular hole, and you can see the pseudoperculum lifted up away from the retina. The vitreous is pulled away, and it's left a very large, and this is also a very old macular hole. So in summary, macular holes generally occur in the 6th decade, although occasionally in the younger age. The female to male ratio is 2 to 1. They're actually about as frequent as retinal detachments, which is about 1 per 10,000 per year. The standard of care at this time is a pars plana vitrectomy with a epiretinal membrane peeling and or also removal of the internal limiting membrane, and then intraocular gas or air, and then positioning face down for 1 to 3, maybe 7 days.